Okay, now we're going to talk about Hhns. And there are some physiologic differences. There's a little difference in pathophysiology, but the management is near the same. The one big takeaway as far as clinical presentation is that this patient may actually be much more severely dehydrated. So in Hhns, the progression is more gradual because this is more common with type 2 diabetes. The blood sugar is a little high, keeps getting a little higher. They are able to get enough glucose into cells that they're not actually breaking down lipids for energy, so they don't have ketones. They're not likely to be acidotic. But they are having polyuria, and that's where the problem comes in. So they have severe dehydration from that polyuria. All the other things that are happening in DKA, the potassium shifts, the dehydration, thirst, those things are happening, just not the ketones. So what does this look like? Your patient may have altered central nervous system function. They may actually be so dehydrated that they are not, they have some cognitive changes. Severe dehydration, glucose greater than 600, negative urine ketones, pH greater than 7.4. So they're not acidotic, and elevated serum potassium. And again, the potassium is elevated in the serum, but the kidneys have been trying to get rid of it. So when the insulin starts putting it back in the cells where it belongs, potassium is going to drop. Management, again, this patient is going to be admitted to a unit that allows close monitoring. They need to be assessed very rapidly. We assess weight. They're on a cardiac monitor because of the potassium. Glucose and ketones can be done at bedside. The same other labs will be done: glucose, electrolytes, BUN, ABGs, H&H, white count. Fluid replacement, if they are in shock, they get normal saline. So if they have severe hypotension, they're in shock, they're not perfusing, they get normal saline. Otherwise, the fluid is replaced with half normal saline because it corrects the water deficit faster. Okay, that half normal saline corrects their, it allows more to get into their tissues more quickly. So if we give half normal saline and they're not maintaining blood glucose, or they're not maintaining blood pressure and perfusion, we can actually lose more of that, and still they're not, we need to keep some of it in the blood vessels to maintain perfusion. So we can lose too much of it to the tissue. So normal saline if they're in shock, half normal otherwise. They replace quite a lot of that fluid early, and then reduce that rate to 100 to 200 milliliters an hour. Typically, they try to replace half of the estimated loss in the first 12 hours and then the remainder over the next 36 hours. They need to be assessed because of that rapid fluid replacement. They need to be assessed for cerebral edema and pulmonary edema and jugular vein distensions, because we can put them into fluid overload by replacing that quickly. Insulin begins after fluid resuscitation. Again, fluids are the highest priority. They may be on an insulin drip. It's titrated to gradually reduce blood glucose. Potassium, again, is going to be normal to high at admission, but once it gets down to the top of the normal range, they'll probably begin replacing potassium as long as that patient is making urine, making adequate urine, they're also watching the EKG, sorry. So as long as they're making adequate urine, they're watching the EKG, they replace that potassium. Okay, the next section is going to be about hypoglycemia.